Okay, it looks like the number of people joining has slowed down, so I'm gonna go ahead and start. Thank you, everybody. Welcome. This is the second edition of the ETSU Ballad Health Strong Brain Institute Resilience Presentation Series. My name is Wallace Dixon, and I am director of the Strong Brain Institute. The Strong Brain Institute was founded through a 5-year gift from Ballad Health. And in our vision, we are going to try to be the preferred resource for promoting the awareness and empirical study of adverse childhood experiences, for promoting the development and dissemination of evidence-based practices that prevent, reduce, or mitigate the negative effects of ACEs on health and health disparities, and for promoting a trauma-informed citizenry and workforce in the Appalachian Highlands region and beyond. Today, I'm accompanied by a couple of colleagues from the Strong Brain Institute. Ben Schoenberg, who's running the show here, is our research services coordinator, and Michelle Moser in the Department of Psychiatry and also the Center of Excellence for Children in State Custody. I'm going to turn this over to in a minute to introduce our keynote speaker, Michael Cull. Just a couple of notes. I am wearing blue today in honor of Wear Blue Day, which is National Human Trafficking Awareness Day, recognized each year on January 11th. In recognition of this important day and throughout the month of January, Blue Campaign hosts several special events and educational activities. This is actually housed within the Office of Homeland Security. So you can see Michelle, she's also wearing blue. And so glad to be part of that effort. Also, after today's presentation, we were going to follow up with a short survey asking for feedback about today's session. Ben will send that to you. We'll ask 3 questions. One is, what is a takeaway that you had from today's presentation? The second is, what suggestions do you have for future topics as part of our series? And a third will be any other comments or thoughts that you have. I'll add that today we are recording this, and at the conclusion of today's presentation, we'll add the recording to our website, the Strong Brain Institute's website, where we're going to keep track of recordings of all of our presenters. Today, because of the webinar format, we have 2 opportunities for you to give us feedback. One is in the chat, and the other is in the Q&A. And we'll try to separate out the Q&A section for questions that we can try to answer. Otherwise, they may get lost in the chat. So particularly questions you have for Dr. Cull, please place those at the Q&A, and Ben will curate those questions. And as time permits, we will turn our attention at the end of the talk to thematic questions. So at this point, I'll go ahead and turn it over to Dr. Moser.
Hi, everyone. I'm really excited to get the opportunity to introduce Dr. Michael Cull today. I've had the privilege to know and work with Dr. Cull since we were colleagues and both part of the establishment of the Centers of Excellence for Children in State Custody way back 2001, 2002, long time ago. We continued to work together during the years he was Deputy Director of Children's Health for the Tennessee Department of Children's Services. I've been excited about Dr. Cull's safety culture work since he was a featured presenter during the Centers of Excellence Breakthrough Series Collaborative that we were focusing on trauma screening and assessments for babies and young children in 2015. Since the beginning of the work of the founding group for the Strong Brain Institute in 2018, I've been advocating to find an opportunity to have Dr. Cull share his work with us. And today he's finally here. I was going to read some of the details of his bio sketch so I get it right. Dr. Cull is an associate professor in the Department of Health Management and Policy at the University of Kentucky, and he's also the associate director for Safe Systems in the Center for Innovation in Population Health. Dr. Cull's work focuses on quality improvement and system reform efforts in child welfare. He has specific expertise in applying safety science to improve safety, reliability, and effectiveness in organizations. His approach leverages tools like organizational assessment and system analysis of critical incidents to build team culture and help systems learn and improve. Dr. Cull served as Deputy Commissioner overseeing the Office of Child Health for Tennessee's Department of Children's Services from 2014 to 2018. Prior to this appointment, he was an assistant professor in health system management and Vanderbilt University School of Nursing and the director of education and dissemination in the Office of Quality and Patient Safety for Vanderbilt University Medical Center. In addition to clinical practice as a faculty member in child psychiatry at Vanderbilt, he also previously served as executive director of the Community Mental Health Center, administrative director of the Department of Psychiatry Patient Care Center, and the director of the Centers of Excellence for Children in State Custody. He has a strong clinical background working with vulnerable populations and extensive experience with organizational evaluation and improvement in healthcare and human services. Dr. Cull is also a licensed nurse practitioner with a specialty in child and adolescent psychiatry. He holds a Master of Science in Nursing degree from Vanderbilt University and received his PhD from the Institute of Government at Tennessee State University. And with that, Dr. Cull, we're really glad you're here, and thank you for talking with us today.
Thanks, Michelle. It's so good to see you. There's nothing more painful than having somebody read like a long bio about you, and mine just sounds like I can't hold down a job. So thank you all for having me. So I'm going to be talking, as Michelle said, about the work that I currently do and sort of how I got to where I am in doing this work. Currently, I'm at the University of Kentucky, although I saw someone do a shout out from Nashville. I still live and work from Nashville. Much of my work is supported by a Casey Family Programs, a national foundation to work with child welfare systems around the country. So the examples I use today will draw on that work from child welfare, but I'll talk about examples from other settings like healthcare, and I certainly am a faculty member. So for those of you who are part of university faculty, I'll try to relate some of this specifically to that workforce too. We're currently engaged in with Casey Family Programs to develop a national quality improvement collaborative that's modeled after similar quality improvement collaboratives in what we call safety critical settings, places like healthcare or aviation, where entities come together and share low base rate safety critical data across a large number of systems for the purposes of learning and improving. So an example would be operating rooms coming together in some structure like NISQIP, which is a really large collaborative nationally, and sharing data on things like retained foreign bodies or wrong side surgeries or surgical site infections, things that don't actually occur very often in any one health system. So shared across a large number of health systems, we can kind of get at those potentially otherwise inaccessible learning opportunities. And then we build from that quality improvement initiatives, and all of it anchored to a particular kind of culture that we're trying to create in safety critical settings. And I'll talk a lot about that today. So we currently have 26 child welfare jurisdictions engaged. It's over half of all kids in public child welfare are covered by this collaborative, which is called the National Partnership for Child Safety. Tennessee is one of the jurisdictions that was a part of the initial cohort of 8 before we kind of rapidly grew to 26. So I'm going to share my slides. I think that, as Wally said, I think Q&A can go into the QA feature on Zoom, and we'll be monitoring that. We won't really be monitoring the chat, although I'd like to, excuse me, I'm sorry. I will use the chat for one activity on one slide. Let me turn this off, I apologize. So, as I said, I'm going to be talking a lot about organizational cultures and a particular approach to developing a particular kind of culture. We're doing this work largely in child welfare. I've had experience when I was at Vanderbilt working in the Office of Quality and Patient Safety, doing this work in a health system. And then more recently, we've begun doing some conversations about how to apply some of this stuff to a faculty in a university. I sit in the College of Public Health and Health Management and Policy at University of Kentucky. So a lot of you have probably seen or heard some version of this quote. It gets switched out. Sometimes it's breakfast, sometimes it's lunch when you see this quote. But this idea that culture eats strategy for lunch. Strategies are best intentions. It's what we plan. It's our strategic plans, our practice models. It's the things that we think will happen in our work when we draw it up. And then it gets introduced to our culture. And that's what Drucker meant when he made this comment. And we believe culture is not this abstract idea. Culture lives in our habits and how we solve problems. And that's a really important piece of what I'll talk about today. And we think it's measurable and changeable. So I'll show you some of the work we're doing around measuring organizational culture and the systems we work with and some of the strategies we're employing to shift away from a particular kind of culture in child welfare towards this idea of a safety culture. So here's what we'll kind of cover. I'm going to talk about how this idea of safety science, which I'll define for you, and the creation of a safety culture can help you think about a new view or a new approach to resilience in your workplace or workforce. I'm going to talk specifically about these two concepts, psychological safety and mindful organizing, and how they support workforce resilience. And then I'll wrap up by talking about some of these specific habits and some strategies you can use to build habits in a workforce. So what do I mean by a safety culture? So we borrow a definition from the Agency for Healthcare Research and Quality. They're the federal agency in the Department of Health and Human Services that's kind of responsible for all the work around creating these kinds of cultures and promoting a lot of quality improvement and system change work in healthcare. So they have probably done the most work in this area, and it's related to a child welfare setting. So this is where we borrow a lot of stuff from. So first and foremost, your organization has to acknowledge its unique challenges and then pursue this idea of consistently safe operations. And in places like child welfare or working with families in the context of some system that's working on trauma, or even in just an academic setting, safety may be defined differently across those settings, right? It might be literally the safety of the child, family, and the professionals involved in doing work with them, or it might be this idea of creating a safe workplace for us to do other work. So we as an organization need to be able to identify the unique challenges with getting to that goal of safe operations. You got to create a blame-free environment. This is really, really important. Doesn't mean an environment without accountability, and I'll talk about that, but it has to be a blame-free environment. Blame doesn't motivate safe, effective behavior. So it has to be blame-free and without fear of reprimand and punishment. It's team-based. It encourages collaboration across ranks and disciplines. And so you have to sort of break down those hierarchies if they're in your organization and they're creating barriers. We just surfaced this actually in a faculty retreat we were at, that we recognize at the University of Kentucky, or at least in our department, we have significant barriers between staff and faculty roles. And there's some real clear lines and hierarchies that have developed over time. And so we know from research in a number of these other safety critical settings that I'll reference, places like healthcare or the deck of an aircraft carrier or wildland firefighting, where they're making these sort of high risk, high consequence decisions, that team collaborative decision making is the most safe, effective approach to making decisions. We've kind of moved past a day when we think that, you know, the single cowboy pilot in the cockpit is the safest model, or the surgeon who is solely responsible for making all the decisions about the patient. We know those models are not the safest, most effective models. So we promote sort of a team-based strategy, and the habits and tactics I'll talk about in this talk today are based in sort of a team model. And then you got to commit resources. You got to be serious about it. So how do we get there? A couple of high-level strategies. You have to pursue a new lens. You have to bring to your work a new way of thinking about how humans interact in complex settings. And we all work in complex settings, whatever that complexity may be. So you have to understand bias in decision-making. You have to understand human behavior generally. You have to understand that there's fallibility in our systems and in our humans or our professionals working in those systems. So you have to pursue this different lens. And in particular, you have to pursue this lens, I think, when you're looking back at things that you're trying to improve. And so related to that, you have to ask new questions. You have to be about what and how, and not who and why. So as I said, it's really critical, the creation of this kind of culture we're talking about, that you move away from sort of a punitive, reactive, blame-free kind of approach. And as I said, healthcare went through this, well, they've been going through it over the last 25, 30 years, where they had this history of being really punitive and blaming when something would go wrong in a hospital. We've certainly, in the area I work in child welfare, have that history still. We're very reactive and very quick to blame when something goes wrong. So if we really want to improve our systems and keep the next professional from making the mistake or reduce burnout and build resilience into our system, we have to be about understanding the what and the how, and not just who and why. And then we have to expect different preconditions. We have to get serious about creating a safe, engaged workforce and giving them the tools they need to do their job. So across the helping professions, these data are from the literature in child welfare. I'm going to actually show you some of our data from child welfare, and it's really similar. What we see is really consistent with these data. I actually, because I wasn't sure exactly how many educators would be on, and I went and looked. There's not a whole lot of new stuff, but I suspect we would all agree, in folks who are in teaching settings, and my wife's a teacher, that these numbers are probably going up. Numbers on emotional exhaustion and burnout, since they've had to deal with shifting to this new sort of way of teaching, these hybrid models or in person, but with a lot of restrictions. But burnout generally across the helping professions ranges around 45 to 60%. This is doctors, nurses, and as on this slide, child welfare professionals. It looks like a lot of you are doing work with populations dealing with trauma. So we know secondary trauma or vicarious trauma, exposure to other people's traumatic materials is an issue that we deal with in our work at pretty significant levels. In child welfare, these studies, at least 50% reported relatively high levels, and 30% were probably clinical. So we know we're dealing with really high levels, and frankly, we haven't been very successful in addressing exposure to trauma and the things that result from it in the child welfare workforce. I think underappreciated in most work settings is the role of fatigue and its interaction with stress. It's fairly well understood in places like aviation and healthcare. Pilots can't just fly as long as they want to fly. Surgeons can't do as many operations as they want. But in child welfare, for example, it's not uncommon for a child welfare professional to be out all night as in the emergency room as part of an investigation, and then be expected to be at work the next day. All of us deal with those kind of contingencies. Especially over the last couple of years, it's been very difficult separating our work life from our home life, and that can add significant stress and pull from your ability to get meaningful rest and sleep. And it affects the way we make decisions, and in particular, it affects the way we sort of react emotionally to things. So this is this slide I have up is an fMRI of a study that looked at sleep controlled and sleep deprived, which I think was 24 hours in this study, and then asked them to do tasks so they could identify the emotional control centers of the brain. And so you can see in the sleep deprived brain, those emotional control centers are lighting up. They're more reactive. Actually look very similar to what an adult schizophrenic's MRI would look like, or those areas of the brain. And so we know we're sort of more, we probably all experienced it, right? When we're fatigued, we're more emotionally labile. Actually, after long periods without sleep, this sort of metaphorical leash between your emotional control centers and your executive functioning parts of your brain kind of becomes temporarily severed. So you're also more kind of reactive. You're less able to make those higher functioning kind of decisions in your work. So we know things like stress, exposure to other people's trauma, the fatigue we deal with, sort of independent of the work setting that we're in, but in some we're in higher risk than others. They really affect the way we make decisions. So, when we're working in these complex settings, dealing with complicated issues and high work demands, we know that these things can impact the way we make these decisions. And unfortunately, we haven't come up with a lot of really solid strategies for addressing them. And this is why we titled this talk about rethinking resilience, or thinking about resilience from a different perspective, because we've had really decades of kind of applying what we would describe as maybe a wellness or a take care model. And we've seen some results, and there's some definitely promising practices out there. But I think I will challenge you in this talk to think differently about resilience and where we should be putting the focus in our systems. If our real goal is building up our professionals so they can do the work better and be more effective. In the area I work in child welfare, there's some emerging evidence that mindfulness interventions can be effective, but it's really limited, and that is the case kind of across professions. There's little to no evidence in the literature that you can actually sort of apply some strategy and build resilience into a workforce and have them sort of come out the other end being more resilient, effective, engaged, et cetera. Most of the studies are applying a mindfulness intervention. The follow-up is, kind of constrained by the study itself. And then it's often follow-up of self-report of people's practices and not actually looking at outcomes related to this sort of intervention. So I think there's some promising things. Our School of Social Work at the University of Kentucky's got what do they call it? A self-help lab, I think they call it, or a wellness lab that I think is getting some really promising results. But we're really early on, and we worry a lot that it's a limited lens. If your primary focus on building up resilience in your workforce, therefore making your system more resilient, is to focus on asking your professionals to be better at doing something, building a capacity into them that they don't currently have. And then asking them to do it at times when sometimes they don't have the resources to apply those strategies. So it's a really common metaphor. Michelle will know I stole this slide from our friend John Ebert probably 10 years ago. A really common metaphor in the sort of this self-help, self-care world, this idea of putting the oxygen mask on yourself before you put it on the kid next to you, right? It's the help the helper before you help the person you're responsible for taking care of. We like to extend this metaphor when we talk about system resilience, because when you're flying at 30,000 feet in a commercial airline, it's kind of like being on top of Mount Everest. And yes, you might need oxygen if the cabin becomes depressurized. But what they don't say to you when they're doing that debriefing is when you've become lightheaded and you're confused and the kid next to you has started turning blue, do a couple of tasks that we taught you, raise your hand, ask for help, and we'll bring you an oxygen mask. And they don't do that because they know that you're not at a place to be able to make those decisions when the cabin becomes depressurized. They've engineered all those decisions into the system because they know when you've been exposed at altitude to low levels of oxygen, you're not able to make good decisions, not able to do good tasks. And I think that's kind of what goes on with our workforce, certainly in places like child welfare, where we give them these resources around self-help and taking better care of yourself and drinking less and exercising more. And those things are really easy to think about on the Monday morning, right after you've had good rest. And it's easy to walk past the donuts in the break room. But when it's Friday night and you've just brought a sibling set of 7 into a child welfare system, it's really difficult to make those kinds of self-care decisions. So I think it's a very limited strategy. I think it has utility. I think there's definitely things we need to continue working on. But I think there's a different approach to building resilience into our workforce that we should be considering. And we should be thinking about it as a property of our system. So how do we build safer systems that support a more resilient workforce that's able to then get better outcomes? How do we make our workforce more safe, effective, and reliable by way of engineering a safer system? And so there's a couple levels of responsibility in a system like this. Leaders in these systems have to strive to balance system and individual accountability. I said early on in that definition from AHRQ, we need to create these blame-free, non-punitive environments. That doesn't mean an environment without accountability. It means an environment that balances accountability and understands the role of the system in supporting or not supporting safe behaviors and good decision-making in our workforce. And then you have to, as a leader, value open communication, transparency, and you have to be about learning. It has to be sort of a continuous learning and improvement environment. And then, as I also said, it's important to organize into teams. And I think there's a lot of ways to think about teams. Some places it's easier to think about, right? Like an OR or a cockpit, there's this obvious sort of team that you can draw boundaries around. In some places, those teams are ad hoc, they're fluid, they change. But the work of teaming doesn't have to change. And the approach we take to it can be informed by some of those strategies that are effective in some of those other settings. So teams in a safe culture monitor themselves, their colleagues, and their systems for signs of stress. It's a responsibility we should all take on, right? We need to be pro-social in our approach to thinking about our colleagues, their level of stress, your ability to regulate in real time, and things in the system that are putting pressure on your ability to do work. You have to communicate honestly and often. You have to promote accountability on your team. And then there's some strategies that we use to actually anticipate and respond to unexpected events as a unit. This is the essence of resilience when you think about it from a systems perspective. The engineering definition, and the reason we use a spring as the metaphor of resilience, is your ability to expand around unexpected events and then come back to normal operations. It's about stretching and not being brittle and breaking. So how do you build a system that anticipates and responds to those times when your resources are drained, or there are demands that are higher than what you've prepared for, so that you're not brittle, you don't break, you're resilient. So we borrow this model from Cook and Rasmussen to kind of make this point in a slightly different way. They look at systems dynamics. And so I'll oftentimes talk about this from the perspective of a newly minted child welfare professional, but you could apply it to anyone working. I think especially, again, it looked like in the chat, a lot of you are working in settings where you're kind of in a helping profession, you're dealing with families with significant needs. And so this is our professional. I mean, in child welfare, we may or may not have the luxury of hiring someone with a social work degree. Actually, nationally, it's only about 35% of all child welfare professionals have a social work degree. We know in all disciplines, we have a real variety in the way we prepare people, but to this goal of creating a safety culture, we don't benefit from, for example, being able to hire pilots who've trained pre-professionally for a really long time before they hit our doors, or surgeons or nurses or techs in the OR. So this is our newly minted professional. We know that the work we do is stressful. The work we do in child welfare and the work a lot of you are doing, a lot of that stress is exposure to other folks' trauma. We know burnout's an issue. Just by virtue of working in the helping professions, you're at really high risk for burnout. And again, I think in education, the studies I found, I don't know that I cited this, but I found at least one systematic review from 2010 that put that number, emotional exhaustion, which is actually a component of burnout, but it's the one that we focus on in our work because it's the one most predictive of workplace outcomes like turnover, and it keeps our scale shorter. It puts it at about 25%, which is a little lower than what you see among like nurses and physicians and child welfare professionals. But again, I suspect in recent times that number would go up. Fatigue, again, I think we all deal with it, and I think it's underappreciated in the way that it affects our work. And then bias. And when I mean bias here, I'm talking about bias in decision-making of all kinds, implicit, explicit, bias that affects the way we interpret individual differences, and bias in the way we think about decisions that we aren't even aware of. Things like confirmation bias, where we're wired as humans to seek out data that confirms our own assumptions. So if I'm an investigator and I'm going into a house and I have some preconceived notions about what's going on in that house, I'm just wired as a human to seek out the data that's confirming of those assumptions, and I'm likely to discount disconfirming data. So that's the kind of cognitive biases that complicate the way we do our work and make decisions, especially in these kind of complex settings. And then we take this professional and we drop them into what Cook and Rasmussen call work as imagined. And so that's going back to that first slide. This is our strategies. This is our strategic plans, or our practice models, or our best practices or evidence-based practices, right? This is how we draw it up and how we expect it to work in the real world when we introduce it. But what we know is that that never really happens that way, right? This would be, if I had better animation skills, you would imagine this being kind of a fluid model. And what we know actually starts to happen is things start to press in on this professional. So we know there's economic constraints that are somewhat predictable. Budget cuts happen, especially in the public sector. We deal with limited resources and are often asked to do more with less. Priorities shift and drain resources away from the work we do. We know there are some fairly predictable operational constraints, things like turnover. We all have sort of paperwork or administrative demands that get in the way of the work we actually came to do. And then we all have some version of productivity demands that put pressure on our work. And so all this stuff kind of conspires to press this professional who we know already has this sort of mix of things going on out beyond what Cook and Rasmussen define as the error margin, or the margin of safety. And that's where things start to go wrong. That's where safety can't be maintained. And so what we believe is creating a specific kind of culture, introducing a certain set of habits, because again, culture lives in our habits, and introducing a certain way of looking back at problems when they do occur can help you stay right inside that margin. It doesn't keep you perfectly in the center of work as imagined, but it does kind of help you understand where that margin is. And some really simple examples is when systems put in place hard stops, policies, or mechanical blocks that keep professionals from making mistakes. So in the operating room, a really classic example of this is it used to be the case that you could connect anesthesia tubing to an oxygen port and oxygen tubing to an anesthesia port. They were exactly the same size. And so if you're a patient that needs oxygen and you get anesthesia, that's of course a really bad outcome. So they've engineered that out of the operating room. They're different sizes. A human can't make that mistake anymore. In a child welfare context, it might be putting in place a policy like we did in Tennessee that says, if your work is going to take you beyond a certain number of hours driving, you have to have a co-driver and you have to get a hotel at the other end. You in your part of Tennessee know well that it takes a really long time to get to Memphis, but it's not uncommon for our child welfare professionals in Tennessee to have to take one of our kiddos from that part of the state all the way out to Memphis. We don't want them driving back. We had, in response to one of our surveys, we had a quote that resonated with us all. This idea that the specific quote was, without the rumble strips on the highway, I would be dead. So this was one of our child welfare professionals telling us that they were dozing off, hit the rumble strips, and that was what kept them from going off the side of the road. So putting in place those kinds of hard stops that say, you don't have to negotiate with your supervisor or with fiscal about whether or not you're going to get a hotel. We're going to put in place a policy. Those are the important things that keep a system right inside that margin of safety. So we bring 3 strategies to this work that we do with organizations. We do a lot of organizational assessment, and not for the purposes of informing a strategic plan. I don't think we've ever kind of written a report from the organizational assessments that we do, but we have a lot of data now across child welfare systems. We build really specific tools that encourage conversations at the team level in child welfare systems. I think actually Tennessee just went through their 5th round of doing this organizational assessment. I'll show you a little bit of our data from our national data set. We do a lot of work on systems-focused improvement, and specifically on the approach to looking at when things go wrong. So how are you going to look back at something maybe once you've gone beyond that margin of error and improve it so that we can keep other professionals from making that same mistake? You could apply this in any setting. And it's about bringing a systems lens to doing improvement work. So it's about asking those important questions that we talked about early on. We focus a lot on doing it with fatality reviews because they have in child welfare for a long time been very punitive and reactive. When the unfortunate and rare event happens that a kid in the care of a child welfare system dies, we've had a history of being really reactive, really punitive, putting child welfare professionals on trial, firing commissioners, those kinds of things that occur. So we try to bring what a number of organizations like healthcare, and I'm sure education would call a root cause analysis sort of approach to doing these kinds of reviews. And then, as I said, it's very team-based. So we have some strategies for supporting habit development at the team level. Important to the team level work, and actually important across all this work, because 1, we measure it, and 2, it's critical to being able to bring a certain lens to looking at people's work, are 2 sort of interrelated or complementary constructs that we talk about in organizations. 1 is psychological safety. The other is this idea of mindful organizing. Mindful organizing is sort of a teamwork practice that we see in what the literature calls high reliability organizations. These organizations that are really effective at getting the outcomes they desire over long periods of time without significant failures. So it's places like commercial aviation in the United States. Psychological safety we define as this idea that, do I feel accepted, respected? Am I part of a team? Do I feel free to speak up? Speaking up behavior is a really critical part of psychological safety. Can I take an interpersonal risk? And do mistakes on my team get treated as opportunities to learn or opportunities to punish? And I'm going to unpack psychological safety. Actually, I probably gave it away a little bit more, and mindful organizing. Mindful organizing is this social collective capability to detect and respond to unexpected events. It's a team-based set of skills for being resilient in the face of unanticipated events. So what is psychological safety? It's a shared belief. It comes from shared experience. So it really is sort of a team-based construct. It's something you can experience as an individual, but it really grows from your team's interactions, your interactions with the folks you work with. Again, whether that be a really well-defined team, 7 people reporting to one supervisor, or whether it's more fluid in the folks you team with on committees or in ad hoc sort of ways. It's that state of feeling accepted, supported, respected, and free to take interpersonal risks. And again, when mistakes on your team happen, are they treated as opportunities to learn or opportunities to blame and punish? So that's what psychological safety is. What it's not is free from accountability. Again, this is not about not having an accountability model. It's really about locating that accountability in the professional and in the work they do and supporting that kind of accountability model, not one that's sort of top down and applied to people. And then it's not a place where people feel comfortable, because if you're going to hold people on your team accountable, sometimes those conversations can be really uncomfortable, right? So it's not rainbows and unicorns. Psychological safety is not about feeling happy and relaxed and pleasant all the time. It can actually be really challenging and uncomfortable to get to a place of psychological safety. Amy Everson in the Harvard system did some of the early research on this, where she looked at healthcare teams. She was specifically tasked with going in and looking at the relationship between reporting errors on a nursing unit and patient outcomes. The sort of working hypothesis going in would be when we see a lot of errors, we're going to see worse outcomes on nursing units. And what they saw was the inverse. Nursing units that reported a lot of errors actually got better outcomes. And so when they went back in to sort of dig in to that idea more qualitatively and kind of understand the differences between these nursing units, what they saw was these units that what they coined as were being psychologically safe in their work felt more comfortable speaking up, more comfortable talking about problems, therefore felt comfortable reporting those problems and learning from them so they could improve their work and get better outcomes. And so there was this inverse relationship between the number of errors reported and patient outcomes in a hospital context. And psychological safety is getting a lot of traction these days. It's being understood in a lot of different settings now. I think I have one example on a slide about it being applied to a completely non-safety critical sort of setting. And so this idea of working with your colleagues in a way that promotes safety and learning, but that isn't always comfortable, is a really important concept in how we work with one another. And so in Edmondson's work, she kind of lays out this 2x2, this idea that when you're looking at these continuums of safe, not safe, or comfortable, not comfortable on a team, this area down here where people don't feel safe and but they're just kind of comfortable and not speaking up is where people get hurt. And these are settings they don't want to work in. And similarly, when we know it's not safe, but there's a high level of discomfort about speaking up, these are places that people want to avoid. Comfort and safety, I think in one place she calls this the apathy zone. This is where people are not really growing, not progressing, not getting better. So where we want is this kind of sweet spot where people feel safe, but there's a level of discomfort and challenging that goes on in the conversations we have with one another. Speaking up is important, but it's hard. It's difficult to actually accomplish psychological safety, especially if you don't currently have it. You have to put in place opportunities to really promote these conversations that, again, are oftentimes very uncomfortable and challenging. So I'm going to do a quick activity just for a couple of minutes in the chat. I know we have a lot of folks, so we'll see how this goes. We talk about these what ifs when you're trying to build psychological safety on a team. So you've got a working definition now of what it means to be psychologically safe in your work. You know, a time when you felt accepted, respected, and free to speak up, when things went wrong, you know, your team got around one another, or you and your supervisor were able to approach that from a perspective of learning. That's a general idea behind psychological safety. So think about a time when that wasn't the case in your career, if you can, or think about what it might feel like if you weren't in that kind of setting. And then in the chat, put one fear that kept you from speaking up, that got in the way of you feeling safe speaking up and challenging what was going on. So I'll give you an example of what I mean. I'll start us off. And then if everybody, I'll just take a minute, we'll open up the chat if everybody could drop one of these examples in the chat. So my first what if, first thing that would, when I was in a situation of not feeling safe on a team that would get in the way of me speaking up, would be, what if I'm wrong, right? Nobody wants to be viewed as sort of incompetent at work. You want to feel like you have it all together. So what if I'm wrong is the example I'll use. So throw in the chat for me some examples that you guys come up with. So I'll sort of read selectively a couple of them. What if they don't agree? It's a great one. A manager who's created a toxic sort of setting around sexual discrimination, bullies in the workplace. Retribution often comes up. I saw that one. Punishment. What if I'm retaliated against? What if I'm overthinking this? I think is a really important one. It's similar to that, what if I'm wrong, right? It's that that uncertainty that keeps you from speaking up. What if they don't believe me is great. What if I'm speaking, oh, that one went by too fast. The imposter syndrome that we all deal with is a really good one. History of having a punitive relationship. Not feeling supported. Feel free to keep these going. I'll show you sort of how my list plays out. What if I look incompetent? Again, everyone wants to look and feel competent at work. I love that somebody put in there, it sort of maximizes their imposter syndrome. What if I'm seen as negative, right? Speaking up and being challenging, there's a fine line sometimes between, being the person that's trying to challenge in a positive way and just being someone who's viewed as being negative all the time. What if I sound disruptive? What if they get angry? I saw retribution and anger showed up a lot in the chat. And then what if they don't like me? People want to be liked. We have a scale that I'll show you some data on, a workplace connectedness scale that we use with the systems that we work with. And it's becoming a really important construct related to a lot of other important things like psychological safety, burnout, intent to leave the organization. Being liked and connected to your colleagues is really important. The military calls this unit cohesion, and they've spent a lot of time researching it and working on it because they've recognized in their work on reducing PTSD that there's something to this idea of unit cohesion, and those units that are most closely connected, that work closely together and like one another, seem to have much lower levels of PTSD. So I just ran across this, Wally and I were talking about this in preparation for this talk. Oh, sorry. This really nice book that I think has a nice approach to thinking about the progression. It's the 4 stages of psychological safety. It's Timothy Clark is the author. It's a really quick read, but it's this idea of sort of having a path to innovation and improvement, thinking from this perspective of creating safety on your team. And the thing that I really liked about this book was, and might be relevant for this broad audience, is that mostly everything I had read today was in either came from these sort of safety critical settings like aviation or healthcare. But Clark comes at this from a business perspective. He's like a business school professor, I think, and he's focused on sort of more of a general leadership model in business. So I think it's great. But he's got this cool sort of path to creating psychological safety or getting to innovation and improvement. And it moves from inclusion safety, which is that early membership in a team. You're a part of the team, you're wearing the t-shirt, you're valued and treated fairly, but you're not sort of a full participant. And then he moves down all the way to this stage of challenger safety. So there's learner safety, where you're moving past just being a passive member, you're asking questions, you're learning from the group's interactions, to being a collaborator, where you're actually sort of engaging, you've got a voice, you're being constructive, all the way up to this place where you're more comfortable with discomfort, right? I think it's a great term that he uses, this idea of a challenger. And so that's the goal. That's where we aspire to getting our team members to this place where they feel safe being candid and challenging other people's ideas and norms, speaking up about concerns. So this related idea of mindful organizing might provide us with some tools to help us get to this place. The sort of combined effect of the two and the strategies associated with them can help us build the kind of habits that we see in other settings where we promote psychological safety and are able to be effective and safe. So again, this social collective process. I chose this picture because there's 2 really important factors to being effective at mindful organizing. One is pro-social behavior, you have to be really truly interested in your colleagues being successful. You have to be pro-social in your orientation. And then you also have to have this level of emotional ambiguity. You have to be able to hold hope and doubt sort of in equal measure. You have to be hopeful about how strategies, again, this is about being resilient, hopeful about how your strategies will work, but always sort of constantly wary about the impact of things on your system. So you can, again, be working towards anticipating those things that put stress on your system and how you can be resilient in the face of them. Wildland firefighters are really good at this. They actually have a curriculum around mindful organizing. They do a lot of work to think about how they organize to anticipate unexpected events, because wildland firefighting is about a multi-jurisdictional response. It isn't just one fire department. So they have to quickly come together, organize, and do this really complex work. As I said, I think this was my example of outside of a safety critical setting, but Google just recently wrapped up a 5-year study looking at what makes a team effective in a Google environment. And I assume they went into this thinking that they would come out the other end knowing the right mix of professionals, like they needed a data engineer and an MBA and whatever else, a business analyst. What they actually found was what was most predictive of outcomes in the Google environment. It's not safety critical, but they are solving really complex problems, was psychological safety on teams. And then finally, in the healthcare context, we know that these things are interrelated. In a big study, one of our colleagues at Tim Bogus at Vanderbilt did across, I think, 45 nursing units and several health systems. They found that this combined effect, so psychological safety improved patient safety outcomes, mindful organizing improved them. When they saw both together, there was sort of this additional effect by combining the two. So we know these things are really important interrelated concepts across a number of settings. We've now done our organizational assessment work and begun working with teams in child welfare. We have about 20,000 now across about half of our jurisdictions, unique responses to our surveys. We measure things like psychological safety, workplace connectedness. We look at turnover using a proxy scale called intent to remain in child welfare. We look at mindful organizing, and we look at, as I said, this component of burnout, emotional exhaustion. So we're starting to see these really interesting and important relationships. When we see high levels of psychological safety on teams, we see higher levels of workplace connectedness, this thing that we think is really important, buffer against things like secondary traumatic stress. We see lower levels of turnover. When we see higher levels of psychological safety, we also see better teamwork measured by this idea of mindful organizing, and lower levels of emotional exhaustion. And then when we see teams that are good at mindful organizing, this teamwork strategy, we see higher levels of workplace connectedness and lower levels of emotional exhaustion. Some of these really intuitive connections, but it's important for us to begin to define them in their data. And then we're beginning to work, one of our colleagues at Northwestern is starting to link these scales, these constructs, to some child level outcomes like repeat maltreatment and length of stay in care. I think I had animations that I forgot to use, sorry. And so I'm going to wrap up, and then I think we'll have a few minutes for questions by talking through some of these habits. It's sort of a distillation of some of the literature on teamwork and building psychological safety into teams. And so how do we bring some strategies or habits into our team context to build ultimately this culture of safety that we want to develop? So first and foremost, well, we have to spend time on our teams identifying what could go wrong. Resilience is about anticipating, right? So we have to spend time knowing what those things are that push our ability to be resilient, whatever context you're working in. So doing things like intentionally huddling, using really simple tools like huddles where you come together and just plan for your day or your week, where you're talking about things in a way that's candid and focused on what could go wrong. So people begin to develop this habit of being constantly wary or holding hope and doubt in equal measures, right? So if I feel comfortable sitting with my chair or my supervisor or the folks I teach with or the treatment team, and I'm actually comfortable speaking up and saying, you know, I'm really concerned about this patient I'm seeing on Thursday, or I'm anxious about this thing that's happening next week. You build in those opportunities for candid discussions and creating psychological safety, but you have to be intentional about it. Asking the question, like, what are you concerned about, is one of the most effective strategies you can use for building this. Talk about mistakes and ways to learn from them. Again, treat mistakes as opportunities to learn. We have plenty of opportunities to hold people accountable. We have less of is opportunities to take our mistakes and really build people up. And we all make mistakes, so we can anticipate that it's going to happen in our careers. You have to be about a change mindset, and everyone should be empowered to be a part of improving your system. So when you're going through this process of thinking about the things that went wrong, you have to feel confident that you can speak up and talk about ways to test norms and change processes and do work differently. Developing understanding of who knows what and communicating is really more important when you're being resilient in these settings, these sort of safety critical settings where, for example, I'm bringing that sibling set of 7 into care. I need to know who knows what, and I need to know who I need to communicate with and what information needs to be communicated at important times. But this is important in all settings. I think if you were doing a general workplace engagement survey and asked some question about communication from leadership, you could pretty predictably get low scores that people sort of always feel like they're not getting the information they need. Appreciating your colleagues and their unique skills actually operates kind of on 2 levels. There's some pretty good literature on sort of intentional appreciative acts in the workplace and its ability to reduce not just burnout or emotional exhaustion, but even symptoms of depression in some studies of residents and nurses. And so doing some really intentional appreciative acts, even as simple as like being intentional about smiling and asking things that are appropriate but are personal, like about people's weekend or about their children, writing notes, all the way up to these really structured interventions like 3 good things, which I'm happy to share afterwards, where you have people journal at night for a 2-week session, 3 good things that happened to them during the day. We're really good at internalizing and laying in bed and ruminating about that one bad thing that went wrong. And we know that we encode that stuff as we sleep. We're really bad at focusing on the good things that happen. So it can have a lasting effect on things like burnout and signs of depression in a workplace. And then finally, candor and respect have to be a precondition to the work we do. It can't be a priority because priorities are lists and they shift. It has to be a precondition. We have to be about being candid and being able to be respectful in the way we interact with one another. Went a little fast at the end, I apologize, but I think I've left a couple of minutes if there's any Q&A, Ben, that you want me to address.
Thanks, Dr. Cull. There is one question in the Q&A specifically from David Shoham. He is asking about the relationship between social capital as a protective factor for burnout. He's working with a PhD student, and the PhD student's dissertation is on nurse burnout. So again, if there's any research, or if you know about any research or have done any research about psychological safety or social capital being a protective risk factor for burnout.
I'm going to say I'm somewhat familiar with the social capital, and I know we have some colleagues and I think this is a tool that they use in that discipline, this sort of connecting social networks and doing that social networking analysis. I think what we believe, and we've been talking to one of our colleagues recently about that, is this idea of, again, what I think is most well developed in the Department of Defense or in the military, this idea of unit cohesion, what we call workplace connectedness, but just generally speaking, this idea of, how you're related to your colleagues. Needing to be liked was an example used in the psychological safety examples that I was giving. I think it's a critical piece and often overlooked because, especially I think maybe as the more professional we might get, the deeper we get into organizations, or the more organizations have people with titles and degrees, the more we think their work is just prescribed, right? You're a professional, you've been trained to go do your work. And we underemphasize this idea of interacting with our colleagues. Paul, gosh, I'm blanking on his last name, but many of the strategies we use come from first crew resource management that was developed in aviation, which was, you can engineer most safety concerns out of an airplane, but then you get down to that percentage, whatever it is, where it's humans interacting with one another. Safety in the cockpit where the co-pilot feels safe speaking up, those are not able to be engineered. So they developed a curriculum called crew resource management that's been translated into healthcare called Team Steps. But the first surgeon that introduced that into his OR, and he's in the Harvard system, was starting to get really great outcomes, but people were having a difficult time replicating it. And what he'll tell you to this day is that what he thinks made his approach more effective was not that they were using huddles or doing timeouts or checklists, these things that you probably are all familiar with, but that he was getting his team together every Friday. They were eating together at lunch and they were talking about what they were going to do this weekend and their kids playing baseball and those kinds of things. So I think it's oftentimes, I'm really excited to hear about that research if I can somehow get follow-up. But I think that social aspect, or again, what we call connectedness, is a really important aspect of this.
Thanks. And it looks like we're getting close to the end of time. I'll throw out this one quick question. Corrective actions when an organizational culture has poor psychological safety.
You know, that's an interesting question in the way that it's phrased, because I would say, you know, culture doesn't change quickly. And again, you know, the way we operationalize or think about culture is this idea that it lives in your habits and the way you solve problems. And so, and we identify poor cultures, or we identify certainly low levels of psychological safety, and we would sort of generally describe our scale as an organizational assessment of culture. Corrective is not what we are, really. It's about going in and helping folks develop new skills. And you can't just wake up tomorrow and have better habits, right? We've probably all been through that. Like, I want to be healthier, so I'm going to start running. I've got to get up and actually go run, and I've got to do it long enough that it sticks. And so, you know, developing habits that support this in the workplace is the strategy. I'm happy to share all of our materials to you. We have, I'll show all the scales that if people are interested in them that we use. And then we have sort of a curated set of strategies that we think support this habit building that I'm happy to also share. Ben, maybe you could send it out.
Yeah, I'd be happy to connect folks to any resources you have. There was something funny here in the chat I had to read real quick. It's easier to change your culture if you're a microbiologist than if you're an anthropologist. I don't know if that's true or not, but I can see that we're getting close to the end of time. Dr. Cull, I really appreciate your time. We all appreciate your time. And we will definitely connect folks with you, your resources, and any other questions that will come from the survey that I'll send out tomorrow to registrants. Please send us any questions or concerns and fill out that survey if your time permits. Dr. Dixon, would you like to end things or say anything before we get off? I think you're muted. You're muted, Wally.
Of course I'm muted. Thanks to everybody for coming today and joining with us, and stay tuned. We will take your email addresses and add them to the SBI external listserv so that we can announce future talks. We're planning one of the talks of the series once a month. So stay tuned. Thank you. Have a great day and a great rest of your week. And thanks, Dr. Cull.
Thank you for having me.
Thank you all.